The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, Eric back with you. Today I got a really awesome show. I got a colleague, a buddy that met a few months ago. His name's Tyler Christifulli, and he's the host of the Lifestar podcast. Been very impressed by his content and really want to start doing more things, more podcasts, more projects with him. So invited him on the show and to kind of promote his podcast and let all the FlightBridgeED listeners kind of hear his way of explaining things and his way of teaching, which I've found to be very dynamic, and I've been very impressed, as I said. Before I get started, I just want to introduce him again, Tyler Christifulli, and just say welcome. And how are you?
Good, Eric. Thank you so much, man. It's my pleasure.
I'm real excited. I mean, we've talked a lot on Twitter over the last, we've maybe 8 months and started slowly building a dialogue and talking about different things. I've been very impressed with the content you post on Twitter, all the little experiments you do. And that's the thing that we were talking back and forth last night that I look to, try to partner with people is number one, are you humble? Number two, how do you articulate yourself? Are you dynamic? Do you teach in a way that comes across so people kind of are drawn? And I think you do. And do you back what you do with evidence? Those are the three key things that I really look at and want to partner with people. And so, I think that you've done a really good job, and hope we have a long relationship.
Thanks, man. I appreciate it. I started listening to the FlightBridgeED podcast when I was studying for my FPC exam. And even after I completed the exam, there was just so much that I'm like, you know what? I got to stay up to date on this stuff. I want to stay fresh with it. And so I just continued listening to it ever since. So I really appreciate what you guys do, and the product you're putting out is just phenomenal.
Cool, man. Well, I appreciate those nice comments, and I think it's people like you, and it's all the word of mouth, and to see the growth of the podcast is cool. So today's podcast, guys, we just did a podcast the other day, and it was adult versus pediatric BVM. Just was a quick 10-minute podcast. I recorded it while we were in Hawaii, and I cannot believe the response this podcast has had. I mean, my phone is getting blown up every day. Twitter, emails, absolutely hilarious that a podcast like this, we're a critical care podcast, and a BLS kind of maneuver like this is just causing just a stir. So Tyler had told me he was planning on recording something along these lines, and I thought, man, what better way to kind of follow up this podcast right after the first one and kind of touch on the different ideas and different concepts that people have sent me. And then he's done a lot of research, so kind of expand on that podcast and go to it. So on today's podcast, guys, what I'm going to do is kind of facilitate the discussion, and I'm going to let Tyler kind of take the lead on this, and I'll just add my 2 cents and try to just have good dialogue back and forth. So Tyler, why don't you start off and kind of tell us the question at hand? Why are we doing this podcast? Why is this such a big deal right now?
So I think the question at hand is, can we use a pediatric BVM to not only safely ventilate adult patients, but also satisfy their capnic and oxygenation needs with it as well? And we all know that the BVM, the adult BVM, has the potential to deliver well over the recommended tidal volumes for adults, according to the lung protective strategies and some of the studies we've seen from the ARDSNet. And so I started looking at this, and I realized that there are services that are going to hospitals and taking patients off a ventilator and bagging them throughout the transport. Or maybe they even fall into the putative process of bagging the patient till they get to the helicopter, to the ambulance, and then putting them on the ventilator. And I thought we need to look at the BVM a little bit closer, because if I was reviewing a chart and I saw they had the tidal volume set at 900 cc's or 1,000 cc's, I would think the crew was off their rocker or they were ventilating Bigfoot, because we don't ventilate patients with that high a volume. We know the deleterious effects that can have. And so we started looking very closely at this. And I read some studies showing that you can actually use a pediatric BVM to get a more consistent volume when ventilating patients. And so that's what I wanted to talk about with you, is utilizing that pediatric BVM and seeing if we can get safe ventilation, adequate ventilation for our patients by utilizing that. And the question that comes up most commonly is, well, can I oxygenate my patient using a pediatric BVM? And I have to reference the alveolar ventilation curve, because it is phenomenal just to look at this graph. Because what you can see is as you increase the FiO2 of a device, you need very little actual alveolar ventilation. So if you look at this curve, you're going to see on the x-axis is alveolar ventilation in liters per minute. And then on the y-axis, you have PaO2, and that's with a capital A. So we're talking alveolar ventilation. So as long as you got a clean VQ ratio, you should be fine. Now, when you look at this, at an FiO2 of 50%, which we know the BVM is capable of providing at least 50%, you only needed about 1 liter a minute of alveolar ventilation to oxygenate the patient. And this curve actually comes from a study that Rich Levitan and Scott Weingart had done on pre-oxygenation, and showing that we don't need to bag our patients to get their pulse ox up. We don't need to excessively bag them. Now, am I telling you only to deliver 1 liter per minute? Absolutely not, because this wouldn't satisfy their capnic needs. But I do think that this helps us put into perspective how much we actually need to ventilate to oxygenate the patient.
No, and I think you're absolutely correct. And I think that the idea, and I posted this on Twitter yesterday, the idea that we have to automatically pull a BVM out is so 20 years ago. And just you relating this and pulling a lot of this data from Scott Weingart and Rich Levitan's study. I've quoted that study on many occasions in other podcasts, not only with the passive oxygenation, but the groundbreaking concepts they identified with paralytics, the difference in paralytics. And I think passive oxygenation, it's here to stay. And I think that we are so knee-jerk in going back to how we were taught in EMT basic school, or how you were taught maybe if you were in the beginning stages of nursing school. And we grab a BVM every time, all the time, grab a BVM, and we forget that Graham's law, just a simple law of diffusion. This graph illustrates what you said perfectly, that we don't need all this extra oxygen. We don't need this huge amount. And if we ventilate our patients properly, as long as they're moving some volume, if they're breathing 4 to 6 times a minute, if you can give them passive oxygenation, I think right there, you're alleviating a lot of this problem. And I think that's the big thing, is it comes back to training and a culture change, remembering to put a cannula on every patient, remembering to put an on-rebreather on every patient, and try to maintain or get that SpO2 greater than 93%, or at that 94% range, and remembering that 96, 97, 98%, that there's such a small margin of utility. If you look at it's the same type of graph right here. If you start looking at that graph, and understanding that above 94%, the utility is just not there. I think, yeah.
One of the things I've noticed is if you watch a crew in simulation or even on an actual call, they start off with the EC clamp and they're bagging with one hand with an adult BVM. But as soon as they get the patient intubated, what happens?
With 2 hands. Yeah.
They use exactly. They start using 2 hands, and it just happens kind of intuitively. They're not even paying attention that they're doing it, but they've freed up their other hand, and now they can use that. You could actually probably get away with using 2 hands when you're doing the EC clamp because of how crappy the seal actually is with it and the anatomical dead space. But now we're putting an ET tube in the patient. We're cutting down on that dead space, and then we decide to deliver a much bigger volume by squeezing the bag with 2 hands. And one of the things we were just talking about is the difference in total bag volume when you look at these different manufacturers that make the bags. And I sent you the product specification for the Rush bag, which is the one we use. And that's got, with the adult BVM, that has a total bag volume of 1,500 mLs. Now, the average stroke with one hand is about 600 mLs. And then the average stroke volume with two hands was 975. And anecdotally, I've seen that even higher than that. Now we look at the pediatric bag, and this has a total bag volume of 900 mLs, an average stroke volume with one hand of 600 mLs, and an average stroke volume with two hands of 690. So look at the difference between a one hand to two hand with an adult, where you go from 600 to 975, and then a one hand to two hand with a pediatric bag, you go 600 to 690. So it's only a 90 ml difference. And so that was one of the things that really attracted me about the pediatric BVM, was that if somebody accidentally fell into the act of squeezing that with two hands, they're only getting 90 more cc's. That's not really going to make that big of a difference. Where if they do it with an adult BVM, I mean, look at that. That's quite a big difference, going from 600 to 975. And so this really attracted me to this. But then if you look at the Ambu bag, the total bag volume for the adult is 1475. So, not that much different. But the pediatric bag is 450. So that's significantly less, because the approximate bag volume with the Rush bag was 900 cc's. So I don't know about you, Eric, but I thought that well, all of these must be the same. They're all BVMs, a pediatric BVM and an adult BVM. I didn't think there was going to be that much difference between that total bag volume. So what this forced us to do was actually look into, okay, what is our manufacturer of our BVM? And I think that's going to play a lot into, are these ventilations adequate? Because when you use something like the Spur 2 Ambu bag, those ventilations possibly could get up to 400 to 500, but you might have a bigger patient. Those might not be adequate to satisfy their capnic needs with that. So that was really interesting with me to see that.
Well, and I think, you say you use that Rush bag, and so I want you to kind of go into some experiments that you've done. And have you seen the data that's product specific with this Rush bag? Did that match your experiments? And kind of explain your experiments, and so I think that is a pretty imperative thing for me, is seeing you demonstrate this, and we can share that on Twitter. You can go to either of our Twitter page and we'll share that information. Yeah,
one of the things is, you can read this data, but to actually see it for yourself is a whole nother thing. And so what I did is I did some anecdotal research, and Jim Ducanto, Dr. Ducanto gave me a Michigan instrument. It was 5600i dual test lung. And he said, yeah, you can borrow it for these experiments I was doing, because I had a airway resuscitation academy coming up. And so I tested these out, and I kind of blinded our providers to how much they were actually delivering. And I said, just squeeze the bag and squeeze it like you would on a patient. I had them do it with one hand and two hands. And there's no dead space. This is directly connecting to the machine, but I was seeing these tidal volumes commonly exceed 1 liter with an adult BVM. And when they used one hand, it was almost up to 900.
Wow.
And I'm like, wow, that's crazy. In the ARDS-NET era, and we're seeing these, try to keep your tidal volume 6 mLs per kilo, try to keep your plateaus low. We don't have a way of measuring plateau pressures on a BVM. So it's really a good idea to err on the safe side. And I see that safe side leaning towards the pediatric BVM, in my opinion.
Well, I think that's interesting. So a few things that I want to kind of ask is, I think, was there a difference if you had a female versus a male? I think probably male-wise, I'm not going to say ever, but I predominantly will not squeeze a BVM with two hands, because I've got big hands and I can squeeze that BVM with one hand. Females, I think, predominantly have small little hands, and so they're probably more apt to grab that BVM by two hands. So did you see any differences with your male and female employees, or notice?
Absolutely.
Okay.
No, absolutely. I did. I'm glad you brought that up, because how often in medicine do we dose a medication, and I view ventilation as a medication because it's something that we're delivering, how often do you dose something based off of the provider? It's always based off of the patient, right? That's not the case with ventilation. If you're using a BVM, you're dosing that off of you, whether you decide to use two hands, whether you decide to use one hand, and based off of how big your hands are, your grip, where you grab it on the bag. I was talking to Tom Boothele from Hilton Head Fire, and he was saying that the Seattle Fire Department will actually have them grab kind of the distal end of the bag and then put their pinky in the air to remind them to give a small breath because they recognize the excessive ventilation that can occur with an adult BVM. And so I thought, if you see the difference between a one hand and a two hand on this bag being 90 cc's with a pediatric, and then you go to the adult and you see it being over 200 cc difference, that was a selling point to me right there. I thought, wow, that is really cool to see that. But talking about this, I'm like, I'm sold. I love it. I think this is a great idea. I talked to Dr. Jeff Jarvis down in Texas about it. He's like, yeah, it sounds like a really good plan. He was even looking into doing some research on it. And I thought, okay, I'm sold. Should I throw away my adult BVM? Does that mean my adult BVM is obsolete at this point? And the answer is absolutely not. And the reason is because I think the adult BVM still has its place when we are face mask ventilating a patient. There was a study done in 2010. It was in the anesthesiology journal. And what they did is they took anesthesiologists and they had them ventilate a patient with the EC clamp. And then they had the anesthesiologist ventilate with the thumbs down technique. And so I'm going to read you just some numbers. And they did 5 breaths with each one of these techniques. With a one hand EC clamp and squeezing the bag with one hand, and this is an adult BVM, they were getting, the first breath was a tidal volume of 412. I was like, wow, 412, that seems really low. Breath number 2 was 444 cc's. Breath 3 was 453. Breath 4 was 467. Breath 5 was 455. So it seemed like they went up a little bit and then they went down a little bit. And I'm like, this is crazy. The adult BVM is capable, it's a 1200 cc bag for the most part. Even some of these we saw was a 1500 bag. How are they getting such low tidal volumes out of this? And you have to think about the dead space. You have a lot more anatomical dead space. We know dead space is a 1 pound or 1 cc per pound of ideal body weight. And so if you were to use, you got this 1500 cc bag here and you're ventilating a patient using face mask technique and you're only getting 412 in. Imagine if I were to take that and use a 900 total bag volume BVM. My delivered tidal volume with the leaks and stuff really would be a lot less. So I just did a podcast on this as well, a strong advocate for the two-hand technique. I think that we can always find somebody to help us squeeze the bag. I think that distracting the jaw anterior, doing the head tilt chin lift and the jaw thrust, and using that two-hand technique is beneficial. But this just drove the point home for me because when they did the two-hand technique, the first ventilation was 454, the second one was 500, and I think the highest it got was 566. So that's a lot better. That's a lot more adequate. But I think if you're face mask ventilating a patient and you're using the two-hand technique, I don't know what those numbers would be with a pediatric BVM, but obviously they would be lower than this, and this was 566. And so I look at this and I think that there is still a use for the adult BVM because if we're using a pediatric BVM for face mask ventilation, I worry, I think it'll obviously take care of the oxygenation needs looking at this alveolar ventilation curve, but I'm not sold that it's going to take care of the capnic needs or even the metabolic state of the patient. So I thought that was really interesting to look at that.
No, I think you bring up a lot of awesome points, and I think these are some of the concerns I had. When we touched on this with the Second Shift podcast with Mike and Evan, these were the concerns I had is, do they design the adult BVM for that purpose because of that kind of that fudge factor? Or as my buddy Ryan Wyatt, he texted me. He was on our podcast where we did the checklists and the kind of the stop, timeouts. He said, BVMs were kind of designed and invented back when 10 to 15 mils per kilo was the standard range for tidal volumes. This was pre-ARGENET trial in 2000. Is that why? And they just haven't changed it. And you look at this, these are anesthesiologists. These are like the experts of experts for airway management. This is all they do all day long is airway management, and they're getting consistently these volumes. I think another thing, and I know, when you kind of look at the approach, and I did a podcast on damage control RSI. And if you guys don't remember that, listen to it again, because the whole point of that podcast was, number one, to kind of help facilitate Dave Olvera's kind of push for better airway management. And number two, working alongside him, seeing the different aspects of, the 7 P's of RSI, or I've added that 8th P of positioning, right? That all the things that we do in those steps to prepare, it's all BLS, right? There's the ALS aspect of placing the ET tube, but if you don't do all those other little things well, you're not going to be successful. And part of that is, number one, passive oxygenation. Number two, if you do have to go with a BVM, and I know Air Methods has taken this stance, the EC technique is absolutely against policy. It is not all right. It is the 2 thumbs up, using the index fingers at the angle of the jaw, your palms on top of that mask, and using your hands as big clamps. And we have hammered this in HPS. We have hammered this in LMS education because of that exact thing. And the data right here shows the difference, is how much are we losing? And so I guess the point is we got to stop, and we got to come back to reality and remember that these airway management is only as good as our success, right? If we perform airway management, RSI, and we have a adverse effect, if we have a desaturation, if we have a hypoxic event, if we have an arrest, what's the point of doing it, right? Now, obviously, there are sick patients out there that are going to die, unrelated to your airway management. But if we don't stop and slow down, and this kind of goes to what you're saying, there's always going to be somebody on scene that can help you. Even if it's, we teach even rotating the patient's head 90 degrees to where they're facing somebody on the bench. So you have somebody holding the mask, you have somebody holding C-spine, and you have somebody actually squeezing the bag. So it may take 3 people. But that's better than having somebody desaturate, or having somebody, have all this gastric inflation because somebody's not bagging effectively or efficiently. So I think you're absolutely correct. I think maybe, Mike Verkest has talked about with their program in Portland that they have made the decision to use the pediatric BVM for basically intubated or cardiac arrest patients. That they're still going to do exactly what you're saying. They still have the adult BVM on all the engines, and they're going to apply the adult BVM as we have discussed, but they're going to use the pediatric BVM for intubated patients. So is that kind of your approach?
Yeah, absolutely. And let's say you present this to because we know everybody listening to the podcast maybe is not in a role to make a change like this within their organization. And, if you present this and you go, hey, I think we should start using pediatric BVMs if we intubate a patient to use those lung protective strategies, and they look at you like you're off your rocker, one of the things you can do, I think the first step is just being aware that this exists, knowing that you have the potential to deliver these high tidal volumes. The second thing, George Kovacs talks about I think it's George Kovacs. He talks about a football hold on the BVM, where you actually hold the BVM from the bottom. And this prevents you from holding it on the top and feeling like you have to really grip it. You deliver lower tidal volumes when you grab it from the bottom. And so this is something that I incorporated long before we looked at doing pediatric BVMs because of that grip. And, whenever you're looking at ventilation, there's always a toss between, I want to be protective with my strategy. I don't want to overextend the alveoli. But I also, I don't want to deliver such a low volume that I start to maybe lose recruitment. And so there's just this fine line between the two of them. And it's really hard to dial in with a BVM. It's very hard to master. And I don't even know if you could master it because you don't have any quantitative measurements of what you're doing. You're just going off of, okay, the chest is rising. That must be good. They're oxygenating. That must be doing okay. And their end tidal is within normal range. And so I think that putting them on a ventilator as soon as possible is the best thing that you can do. We have adapted in our practice, bringing that ventilator bedside. And what we do is we have the NV ventilator. We connect the NV to our test lung. We match the settings that they have initially. If those settings are crash settings, well, then we're going to customize those. We actually measure out the patient and we'll get what we think is, the best customized settings for those patient. And then we switch them over to our vent. And we watch how they do for a little bit. And we watch to make sure their sats stay where they're supposed to be. And we see how they adjust to, because even if you match those settings identically, for some reason, I'm sure you've seen it, sometimes they just have to adjust to a new ventilator. And then once they've adjusted, then we can take them out and bring them out to the ambulance or the helicopter or whatever you have. But I think that taking them and putting them on a BVM and bagging them, depending on how long that is. But even if it was only even if it was 5 minutes, I still feel like you're reversing some of that flow that they had with that ventilator. And now you're doing it with a bag, and you got all the human factors that play into it. And you got the alarms going off, and somebody's always going to grab it with two hands. And so if that's the case and you're worried about that, the pediatric BVM seems like it's the most consistent with it. But I would go even further and say you probably shouldn't even do that. In my own opinion, I think that the ventilator should come in bedside. That should be done right there. I think the ventilator is a pre-hospital tool. I think that it can be used in the hospital once the until you can get a RT down there and a ventilator down there. But even Scott Weingart talks about VAPOX and using the ventilator as your BVM while you're actually resuscitating a patient, just because you take out those human factors. You get that specific tidal volume in, and you don't have to worry about somebody excessively ventilating the patient. And, one of the things I've heard you talk about, and actually I heard another podcast mention it as well, is, okay, I've had a patient that saturated really poorly on the ventilator. And as soon as I started to bag them with the adult BVM, they improved. And they want to know, why did this happen? And I was listening to you touch on this with your podcast you did, I think it was like a week ago. And you'd mentioned you're squeezing the bag a little slower, so you're going to have an increased eye time, which is one of the strategies we use to improve oxygenation. And I thought about it, and I'm like, you know what? I wonder if they're utilizing PEEP. Because if you're not utilizing PEEP, that's going to change things up a little bit with the BVM. But let's say you have somebody on a ventilator and they're at a tidal volume of 600 cc's or 500 cc's, whatever, and they have maybe 10 of PEEP on. And then you take them off of the ventilator and put them on a BVM because either you don't have a ventilator or you are just taking them out to the ambulance or helicopter. And you wonder, let's say you start bagging them, and essentially what you're doing with the adult BVM is a recruitment maneuver because you're delivering a really high tidal volume. Now, hopefully you have PEEP on there as well, but what that's going to do is that is going to recruit alveoli. But then when you take them off that and you put them on your ventilator, if you don't clamp that tube with that transition, that recruitment maneuver you did that you were like, wow, this is really working well. If you don't clamp that between the BVM and the ventilator, you're going to lose that recruitment. And we said that video you just posted the other day was amazing, seeing how the lungs will shrivel up when that happens. And so I think that we think about clamping the tube when we go from one ventilator to another ventilator. But I think we also have to think about that if they're going from a BVM with high PEEP, because that is a recruitment maneuver that you're doing, and then going to the ventilator with that. And so that was my kind of take on why that could occur. And there's so many, it's multifactorial. There's so many different things that can happen. and the crews are telling you what's going on. They're telling us what's going on. I've had the same thing. I've had people tell me, hey, they did really good with the BVM. They didn't do so well with the ventilator. But the thing is a recruitment maneuver is just that. It is a maneuver. That's a 1 or 2 breath thing. That's not something you do for the remainder of the transport. You have to, like you bring out, match, try to duplicate what am I doing on the BVM that I can do on the ventilator, and not using excessive tidal volumes. But, we know that you gain your recruitment by inspiratory maneuvers, and then we maintain it by utilizing PEEP. And I thought that thinking in that role might help you when you come across this, because the human factors, the inconsistency, the unreliability of a BVM is not something we want to do for a 35, 40-hour transport.
Yeah, no, I think you brought up a lot of awesome points, and I'll try to touch on a few. I'm in agreement with everything that you said. I think I don't have any problem saying, and I'll say it, if you're taking your patients off the ventilator and putting them in a BVM to move them from the ambulance to the hospital or the aircraft to the hospital, that is being lazy, and that is poor care. And I try to be as nice as I can be, but that's one of those things that if you're going to be a critical care provider, that's one of those things. You're going from a critical care tool back to a BLS tool. And there are so many benefits to a mechanical ventilator that you lose with a BVM. And we can't think that they're the same. I mean, a great example, and this is an extreme example, but if you think about a neonate that's got a diaphragmatic hernia, the one thing you do not do with those little babies is you do not ventilate them positive pressure with a BVM. Like, you intubate them as fast as possible when you put them on a ventilator. And that is a great example. We obviously the ventilator delivers breaths that are not physiologic. They're not via a negative pressure like we breathe, but it's much, much different. And I think you lose a lot of aspects when you do that. And you don't have a continuation of care. I think it goes back to a continuation of care. And I think that's a big deal. I've had many flight crews call me after a flight, more than you would expect. You start thinking about them of this exact thing. They could not maintain SpO2s. They took them off the ventilator, put them back on the BVM, bagged them, and SpO2s come up. And it's exactly what you said. And I think that may be a problem with how we've taught, that we've hammered into people that 6 mils per kilo is that starting number, that the ARSNet studies showed 6 to 8, and there's a lot of studies. The podcast that's going to come out next is on all the literature that's ever been published on tidal volumes. And it's a phenomenal study. And I illustrate that 6 mils per kilo, yeah, that's a starting point, but there are some patients based on their disease process, their size, that may need 8 mils per kilo, and you can't be afraid to do that. There may be patients that need 9 mils per kilo. You just never know. 6 is a starting point, but don't be afraid to move up, but just document your reasoning, document and troubleshoot, and do exactly what Tyler just said. Try to identify what you just did with the BVM. You're using a BLS tool and you're improving your patient. It's not the ventilator's fault. We blame it on the ventilator. And I've had these same mistakes. And I'm not saying I haven't, but it's operator error is what it is. It really is. And I've had mistakes where I've realized, well, man, that flight didn't go very well, but you've got to build on that. You've got to be humble enough to say, man, that went really crappy. I'm going to study this. I'm going to, and whenever I had a flight like that, when I first was learning mechanical ventilation, I'd pull that ventilator. That was I didn't even want to touch my chart. I wanted to pull that ventilator in right then and there and play with it, because I didn't want to ever have that feeling again. And I think you have to have that curiosity, and you have to have that. Yeah.
And BVMs don't alarm.
Yeah.
And that's one of the things I tell people, is because they're like, yeah, they did fine on the, they were getting really high peak pressures on the ventilator, but when I pulled them off and I started using the BVM, they were fine. Until BVMs start alarming, we can no longer use that as a surrogate of effective ventilation.
Sure. Yeah. It comes back to exactly what you said. And Ryan Wyatt tweeted that out too, and texted me and said, utilize that underhand technique, you know. And I don't think, you know, for those of you that have done a lot of, you know, working out and weightlifting, if you rotate your arms underhand, you know, and then you instead rotate them over the top, you're triggering and utilizing a lot of muscles. And if your hands are over the top, you actually activate all your back muscles, you know, and that's one of the things that hand placement on the bar and turning your hands, you really do gain a lot of strength by having an over the top grip on something, you know, and I don't think we realize that. And so I think utilizing that underhand technique, like you said, is one way. Squeezing the bag slow so you have that increased eye time. Dave Olvera talks about 3 PSI, right? Watching that chest rise over 3 seconds, squeezing the bag over, you know, watching that bag squeeze and letting that out. That whole maneuver should be about 3 seconds, right? Inhalation, exhalation. And then bagging every 8 to 10 seconds. That's another thing. And I think we see this knee-jerk reaction of, well, we're over-ventilating our patients. Well, we got to slow down. You know, whether that's putting a little blinking light. I know, you know, FDNY, they have the little blinking lights in all their rigs where they can see that, and I'm sure that's becoming very common. I think there's BVMs out there now that actually have that technology on them, I believe. But if not, tell yourself, count every 8 seconds. You know, I think it comes down to those little itty bitty things. And guys, we have to remember that these little things, you know, they really can make a difference in patient outcome. I can't stress that enough. You know, I do expert witness stuff, you know, and on different levels. And it's amazing. A lot of times it's airway management. It's amazing the little things that you see in the care that if they would have just done a few little things different, and it usually always comes down to BLS, the outcome would have been completely different, right? It starts a cascade of events. And we've talked about that many times on other podcasts. And I always say, be proactive, not reactive. And that starts well before. If you're listening to this podcast, you're listening to Tyler and I, you're being proactive. You're being proactive in your education and wanting to invest in your patients. And that's awesome. But it doesn't stop here. You've got to take that now and you've got to apply it and practice it. And, you know, grab a BVM, grab your BVM, find out what manufacturer you have, pull the information out and identify, what do I have here? You know, I think this is a fascinating topic.
I agree, man. I think that a lot of the points you just brought out are things that I've been preaching for a long time. And I by no means, you know, claim to be an expert on this. You know, we're obviously always learning. We're always learning how to utilize our tools and our equipment. But as much as the time that we spend looking at ventilator settings and how to set all that up and how to dial in the specific customizations for each patient, we got to spend that time looking at the other equipment. And I think the BVM is one of them. And I think it's something that we've neglected to really study. And I think this podcast will help out with that.
Yeah, absolutely. You know, remember that, you know, if you're an advanced provider, you know, and I can't stress this enough, you get on a scene, there's multiple people on scene. Usually you're going to have first responders there, you're going to have firefighters there. A lot of times those are the people that we kind of put in place to handle the BVM, right? But we got to remember, and Dave Olvera uses a great analogy when he teaches this, and I've started to do the same thing, is you pull out a laryngoscope, pull out a BVM, and say, if somebody was going to attack me, which one of these could I use as a weapon? Which one of these could be deadly? Everybody's going to say the laryngoscope. But out of those two, the BVM is going to kill your patient way quicker than that laryngoscope is. And I think we have to remember, you as an advanced provider, critical care, you've listened to these podcasts, you've had the top level education from your company, from FOAMed, from wherever you're getting that education. But these first responders, these BLS providers, they're only as good as what they probably learned in their first responder school or EMT basic school. So they may be applying the techniques that they learned 10 years ago, right? So we have to remember, if you're a paramedic, you're a nurse, you're a flight paramedic, flight nurse, you're responsible for that patient in that airway. And you may have to kind of go into teaching mode and watch and make sure we're not bagging 60 times a minute like the studies have shown, that we're not squeezing that bag too hard and too fast. And I think that it comes back to, again, those little itty bitty things will make a huge difference in your patient.
Absolutely, man. Absolutely. And you know what? Don't just take our word for it. Go out there and practice this. I always tell everybody, prove it to yourself. Go get one of these machines. A lot of the technical colleges have them. The one that Dr. DeCanto had let me borrow is now sitting in some other country somewhere getting worked on. So I actually went to our local technical college. I was there actually practicing to do the examination for the new integrated out of hospital. And I looked over while they were teaching us how to do this, and I saw the machine, and I'm like, oh my God, I got to go see that, because I've been looking all over it. If you look, they're like $3,000. I mean, they're expensive machines, but that's the best one that I have seen to actually get a realistic measurement. I've tried other things, but that is what it is meant for. And keep in mind, when I did this, I set the compliance to be the most compliant setting that they had, which is like, I think it was a 0.10 for compliance. And so you can make it harder to bag, but I just wanted to get volumes. I wasn't trying to see anything other than just this year what the volume was of that bag as well.
Awesome. Well, I think we've really hit this pretty hard. Is there any kind of closing thoughts that you have before we wrap this up?
You know, Eric, I think that this is going to come down to a judgment call. I don't think people are going to listen to this podcast and say, ditch the adult BVM. Let's use a pediatric, because we wouldn't, in a critical care call, pick one tidal volume and say, you know what, let's just give everybody 500. Let's just give everybody 600. It's going to depend on the patient. And it's going to be a judgment call. That is going to be something that you say, you know what, the patient's intubated. I think that it would be appropriate, knowing my manufacturer guidelines of what an average one-hand stroke is, to utilize this BVM. And then maybe we say, you know what, I'm going to try a recruitment maneuver. Maybe I use 2 hands for 2 breaths. I dial up my PEEP a little bit to maintain that. So it's really going to turn into a science. It's going to be an art, and it's not just going to be a gross skill of squeezing the bag. So as long as you think in detail, and you think about what you're actually doing to the patients, and you take all these things we said into consideration, you're going to be providing the best care possible. And I think that's what this is all about.
Yeah, and we can't forget, guys, go in a kind of a step-by-step order. Start with a cannula non-rebreather. If you maintain a SpO2 greater than 93%, you can get that up and you can maintain that. This is kind of a moot point. Always have that BVM out and ready for your intubation or your post-intubation care until you transition them to the ventilator. But these are important things, and I think that we have to be ready to apply. And and the last thing is, don't be afraid to add PEEP to the BVM. That should be an absolute automatic for every patient, 5 a PEEP. And I think you brought up a good point, and I meant to say it earlier, is we do hammer on clamping that ET tube, and I wanted to put that video out. I've had that video for quite a while. I wanted to put that out for a long time. It's just been so buried. But if you haven't seen that video, you need to go to YouTube, the FlightBridgeED YouTube channel, or you can look for it on Facebook. But you unclamp, pull that vent circuit off, your recruitment, your lungs shrivel up. If you've taken our vent class, and I've demonstrated this on a pig lung, it's absolutely amazing. So don't be afraid, I shouldn't say be afraid. Don't forget, I would say any patient with greater than 5 a PEEP. I think 5 a PEEP is intrinsic PEEP, but anybody greater than 5 a PEEP, you should be clamping that ET tube. And it does not only apply to the BVM, to the ventilator. It's to the BVM. And I think I forget that. I forget to say that. And I think you brought that point up, and I thought, man, that's true. We're using 10 a PEEP on the BVM. Well, 10 a PEEP is a lot. It's probably really helping with maintaining that recruitment. And so I think that's a important thing, and I appreciate you bringing that up. All right. Well, we will put this in the show notes, and our kind of dialogue, and remember that'll be underneath the podcast on the website. On behalf of Tyler, I just want to say thank you for him for taking out his time this morning and joining us, and got some stuff maybe in the works, and you might be hearing a lot more of Tyler with FlightBridgeED. So we'll keep you posted on that. So I hope you have a great day, dude.
Man, it was an honor to be on your show. I really appreciate you bringing me on and kind of helping me out get my podcast out. So thank you so much.
Yeah, man. And so check out his podcast, Lifestar Podcast. You can search that on iTunes and find that. And again, if you have any questions, email me, eric.bauer@FlightBridgeED.com. You want to give your email?
Yeah, my email is a little bit longer because my last name is super weird, but it's Christifulli, CHRISTIFULLI, and that's at lifestar-ems.com.
Nice. All right, and you can reach out to us, and you can find us on Twitter. But until next time, we will talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.